Hello, everybody. Welcome to March's monthly training. Uh, this month, we're going to be going over management of adult tachycardia, um, more specifically, adult tachycardia with a pulse. So don't expect any cardiac arrest stuff in here. Um, One thing before we start, just want to make it very clear that there are two quizzes for this training. One for the ALS side, so for the AMT and the medics, and one for the BLS side, for the EMTs. Do not take both and only take the one that's appropriate for your license level. If you take both, it's just more of a pain for me to figure out who's actually done the training. If you do the one that's not for your license level, then you're not going to get credit for doing the training. So just make sure you read the links, and we'll go over it at the end too. Do the right quiz, please. We're going to go through the case study real quick. We're not going to review this, but we'll get over to the presentation. So this is going to go over all of our different tachyarrhythmias, kind of general approach to patients that are experiencing a tachyarrhythmia, and then talk about the different treatment pathways with a little bit of protocol review. So sinus tachycardia. This is going to be a sinus rhythm, but with a rate that's greater than 100. Big thing that's keeping it a sinus rhythm is we have this very distinct defined P wave before every QRS. It's regular. So this rate being from 100 to 150. 150 is usually we draw the line for SVT. There could be a lot of causes for sinus tachycardia. Caffeine use, anxiety, dehydration, exercise, sepsis, difficulty breathing. Um, this can be a concerning finding, but it has to be in the right context. So if you have someone who's having difficulty breathing with low oxygen levels and they're tachycardic, that's just another piece showing that there's some sort of oxygen demand that's not being met in the body. Meanwhile, in sepsis, it's comp a compensating mechanism um, for trying to get fluid throughout the body and maintain an adequate blood pressure. In trauma, if you have someone at a sinus tach and this heart rate is above the systolic blood pressure, that could mean that they have significant volume loss inside the body. But a lot of the times, if you have someone with sinus tach, um, really not going to do a whole lot for it. If it's not dehydration, sepsis, um, or some sort of traumatic internal injury that we can't see, there's nothing we're really going to do for this. Uh, and even then, if it's sepsis or dehydration, just a little bit of fluid is going to help bring that heart rate down. So again, if you have someone with a sinus tach, but they don't really have a whole lot of complaints, it's not really going to be a super concerning finding as long as it's in this like lower hundreds rate. Definitely could just be contributed to anxiety. So this can be a concerning finding, but it has to be in the right context. Atrial fibrillation with rapid ventricular response, or AFib with RVR. So this is anyone who's an AFib, but the rate is going above 100. Again, with AFib, we don't have discernible P waves. It's irregular. We're not going to treat AFib until it's above 150 or, hovering around that number. Again, because it's not regular, this heart rate is not going to be consistent. This is like when you throw on the pulse ox and somebody has a heart rate that's kind of flying all around between like 70 or 90 or 80 and 100. Um, that's when you know that you might have someone that's an AFib and throw on the 4 and 12 lead to confirm. So again, AFib over the rate of 100 makes it with rapid ventricular response. Um, but we're not going to treat it until it's above 150. Lots of causes: stress, dehydration, sepsis, cardiac conditions. Medication lapses is a big one. Someone who's on a daily beta blocker but then misses it, uh, then has an episode of AFib. That is not uncommon. Sepsis is a big one, though. You will see a lot of septic patients that are in AFib, RVR, again, fluid for that. But yeah, we will go over the medication and the treatment pathway for this later. Atrial flutter. This is kind of a precursor for AFib. We have sawtooth flutter waves, so they all look about the same. Um, the atrial rate to calculate that is going to be basically however many flutter waves you have times your QRS. So say if you have 3 flutter waves for every QRS and your ventricular rate, so the amount of complexes you have, your QRS is at a rate of 70, your atrial rate is at 210. So the top of your heart is contracting 210 times a minute while the bottom is only contracted 70. And obviously, you're not going to be able to move a significant amount of blood if the atrias are contracted that fast. So that's why a lot of people feel palpitations, lightheadedness, dizziness, some symptoms along those lines. Um, so yep, you have the sawtooth pattern. You get your conduction rate. This is a 3 to 1. We're going to treat this very similar to AFib. It's the same medications. And then again, we have to wait for this rate to get up into the 150s. The one thing with A flutter, it doesn't really, most of the times you see it as a tachyarrhythmia in the field, it's going to be around 150 to 160. So if you're trying to figure out like if it's SVT or A flutter or sinus tach, you definitely keep A flutter on the differential if they're at that rate that's kind of sitting at 150, 160 consistently. You have some risk factors for A flutter. It's going to be hypertension, coronary artery disease, COPD, just generalized heart disease. Makes the heart very unhappy. SVT. So this is where we get over a rate of 150 and our P waves are no longer discernible. You kind of look in between our QoS complexes and you're like, oh, well, is it a P or is it a T wave? You're not really sure. Um, that's where you're more likely to lean towards SVT. We just kind of talked about how an A flutter that hangs out around 150, 160 usually if it's a tachyarrhythmia. So SVT, we're usually more in the 180s to 220s commonly that you see in the field. Obviously, it can be anything over 150, but that's where we're going to see more of it. Triggers for SVT or supraventricular tachycardia, caffeine. So a lot of people who are just downing Red Bulls, Celsiuses in excess amounts, that's going to cause can cause SVT. Stress, strenuous exercise, drug and alcohol use. A lot of people who have SVT, there's a family history of it. It's just going to be due to some faulty electrical signals in the AV nodes. Wolff Parkinson White syndrome. Not going to go too far in on this. There's so much with WPW that it could probably be its own class. We'll probably do that later in the year, but I just wanted to bring it up because this is one where if you have signs of WPW while the patient is in AFib, you're not going to treat this with medication. They have a high chance of going into some sort of dysrhythmia, such as VFib. So we're obviously trying to avoid that. It's a rare genetic condition caused by a re-entry pathway called the bundle of Kent. Over here on this side of the heart, we're going to have our normal SAAV node going down through the bundle of His throughout the heart. And this is kind of the normal um, flow of electricity. They basically have this another bundle here that can cause electrical abnormalities and can cause it to become tachycardic. Um, this bundle over here also causes some very distinct findings on the 12 lead, um, a shortened PR interval, a delta wave, which is just a slurred upstroke of the QRS, and your QRS is also going to be wide. But this having this extra bundle over here, the bundle of Kent, causes these distinct findings, and it also gives a heart basically another pathway to speed up. So again, if you have somebody with AFib and you're seeing these signs of the shortened PR interval, the delta wave, and the widening QRS, you're not going to treat with metoprolol. It can be very, very bad for this patient. If this patient does require some sort of intervention, it's going to have to be cardioversion. So just wanted to point out some of these findings. Obviously, these QRSs are quite wide. You have your kind of slurred upstroke. It's not very defined or sharp. This slurring of the wave here. Um, P waves you can see are very, very close to the complexes. It's a shortened PR interval. So those are your three characteristics for WPW. The last rhythm we're going to go over is ventricular tachycardia or VTAC with a pulse. We're only going to go over the monomorphic. We're not going to really touch into torsades. It's not super common to be a rhythm that produces a pulse. And if it is producing a pulse, it's probably not going to do it for very long. You just know that you're going to go to your mag sulfate very early in that cardiac arrest. It's usually an electrolyte abnormality. But VTAC, it's a wide, regular QRS, tachycardia, and I know AHA kind of separates it between narrow and wide complex tachycardias now. They don't like to use VTAC or SVT, but VTAC is a wide QRS tachycardia. Shape similar to this. It's a peri-arrest state. This patient needs to be treated quickly. If they're having runs of this, or if they're consistently in it, this patient is likely going to code. Um, However, if they're only having like 4 or 5 non-sustained runs, 4 or 5 second non-sustained runs, that's where you're kind of able to treat this with an amnio drip rather than go through cardioversion right away. This is caused by ischemic heart damage, so secondary to an MI, electrolyte abnormalities, and stimulant drug use. Patient assessment. So you don't want to develop a tunnel vision on the monitor. Uh, you're gonna you might see a very high heart rate, but ultimately it's BLS before ALS. We're still gonna treat our ABCs first. If this patient is having a hard time breathing or is not breathing on their own, we're gonna address that, and then we're gonna look at the rhythm. Um, of course, I'll say that with the caveat of if they do not have a pulse, obviously we're doing CPR. But if you have a tachycardic pull or tachycardic rhythm with a pulse, do not develop tunnel vision. There are things that we still need to do. Staring at the monitor that says a heart rate of 200 is not doing anything but probably freaking out the patient. So get a full set of vitals. Treat your ABCs and life threats first. You should get a 4 and a 12. The 4 lead can be very telling of what's going on, but a 12 lead should be used to confirm, especially when you have some decisions to make, whether it's SVT versus VTAC with a Baron C, which we're not going to dive into that this class. That's something that could probably, again, be its own class. So make sure you get a 4 and 12 lead, confirm the rhythm that you actually see. Um, an accurate blood pressure is incredibly vital in these patients. So we really should be getting a manual before we try to use the monitor. Um, this blood pressure is going to probably be one of the things that we use to make the decision between whether or not we're going to medicate or cardiovert this patient. Past medical history is extremely important, especially if you have younger patients who have not experienced this before. That's a really good thing to know to pass on to the hospital. Or if you have a younger patient that is experiencing some sort of tachyarrhythmia, they do have a history of it, they're probably going to be pretty well versed in their condition. They might be like, hey, I'm having these symptoms. I'm pretty confident I'm an SVT, which can make your job a lot easier. But make sure you're getting a full past medical history. Um, Medications are big too, can kind of, if they're on a bunch of beta blockers, you can say, oh, good chance that they have like AFib, especially if they're also on a blood thinner. So past medical history, very important. Some common signs and symptoms we see with these tachyarrhythmias: shortness of breath, chest pain, palpitations, fluttering in the chest. Uh, People can be diaphoretic, have lots of anxiety. They can pass out, feel like they're going to pass out, or be lightheaded. Altered, definitely unconscious, cyanotic, weak. These are all signs and symptoms where if someone is complaining of this, make sure you pay attention to the rate when you're gathering vital signs. Treatment pathways. So whether we're going to medicate or cardioversion, the Edison versus medicine debate. So this is all going to come down to stability of the patient. Um, a stable patient has kind of funny to say it, but a stable perfusion status. So they have an adequate blood pressure, adequate SpO2. They're alert and oriented. They're not having crushing chest pain. They're not so short of breath they feel like they can't breathe at all. Um, their skin condition looks well. That's just meaning they're not diaphoretic and incredibly pale. Um, this is not a patient that you walk through the door and you're like, oh, they are sick. Um, that's more where we go to our unstable side of things. So poor perfusion, signs of shock. Hypotensive, they have an inadequate SpO2, and you have to supplement their oxygen if they're not usually on any. Or if they are on it, you're given a lot more. Altered mental status, unresponsive or lethargic, crushing chest pain, significant shortness of breath, uh, repeated syncope. This means that we are not perfusing the body well, um, and they're more likely to be categorized into this unstable category, which means that we're going to use cardioversion over medication. Stable patients get the medication, unstable is going to get cardioversion. So let's just go through our meds. Adenosine. So this is going to be used for SVT and can be used for monomorphic VTAC. Very, very less likely to use it unless if you're unsure if it's SVT versus monomorphic VTAC and you want to just slow down to um, kind of see what the rhythm is as it ramps back up. That's definitely a strategy. Dose 6 milligram IV push with a normal saline flush. A lot of people also will just have a bag of fluids running and go into that Y port, pinch it off above the Y port, fast push this, and then let the bag flush it in. Um, Repeat doses 12 milligrams, fast IV push twice. IV placement, 18 in the left ACs, your most preferable. You want something that's big and close to the heart. It's going to help this actually work. Indication, stable, our keyword stable, narrow complex tachycardia. Contraindications would be unstable patient, any other rhythms other than a narrow complex tachycardia, and AFib with Wolff-Parkinson-White's. Um, how does adenosine work? It activates potassium channels, inhibits calcium channels, which temporarily blocks electrical conductivity at the AV node, which helps terminate your reentrant rhythm. Special note, before you push this medication, make sure it says hint, but you're going to hit print on the rhythm strip. Um, a few big things for this. You want to see the conversion. These patients usually go have a few seconds of asystole, and then they have a few ectopic beats, and then we'll either go into a sinus rhythm or ramp back up to whatever they're in. So a few things very helpful here. Cardiologists like to see those first few beats after a conversion, way above our pay grades and anything I'll ever understand, but it means something to them. They like to see it. Um, the other thing being, if you're unsure if it's a SVT, VTAC, or if it's AFib, but it's just at such a fast rate that it looks regular, you can kind of watch on the rhythm strip the rate pick back up, and it can help you determine, oh, were we using the right medication, or should we switch paths to correctly address this rhythm? Because there's some times where our rate is so fast that we don't really know what it is. And that's kind of why they start to use this narrow complex tachycardia or wide complex tachycardia verbiage. Amiodarone. So when we give it for a patient that is conscious or unconscious but with a pulse, that patient should probably get cardioverted. But a stable patient that has VTAC, we give amiodarone in a drip. So it's going to be 150 milligrams in a 100 ml bag of D5W over 10 minutes. Um, Indication, again, stable, wide complex tachycardia. So usually VTach with a pulse. Contraindication would be any other rhythm, unstable VTach with a pulse. This reduces depolarization and prolongs repolarization, which kind of helps bring the heart into a more normal heart rate. Um, by reducing depolarization, we're not firing the signal for the heart to contract so fast. And prolonged repolarization means we're going to take more time to reset the heart's electrical activity to get prepared for the next beat. So that's kind of a very vague general overview of how amiodarone works. A special note, if patients receive both doses um, during a cardiac arrest of amiodarone, so the 300 and the 150, um, we're not going to hang the strip. This is a conversation you can have with med control, but amiodarone is such a potent drug, and it also stays in the body for a very, very long time that they really aren't supposed to receive more than this 450 dose. Um, that's why we only carry 450 in our drug boxes. So if a patient you have ROSC and they're going into VTAC, that's where you're probably going to cardiovert. Again, always have conversations with med control, but again, you're probably not going to exceed this 450. It's a very, very potent drug, and it stays in the system for a long time. Metoprolol, this is the dose is going to be 5 milligrams over 5 minutes. You might hear 5 and 5 over 5 thrown around. That's because it's 5 milligrams and 5 mLs, and it gets pushed over 5 minutes. Um, Indication AFib with RVR or a flutter over 150. How it works, it blocks the beta 1 adrenergic receptors. Basically, neurotransmitters won't be able to bind to this site, which would be excitatory. So it's going to reduce the heart rate and contractility. So it should help reduce that rate. Special notes, you are required to call medical control to give this medication. The big thing being, you're probably going to want to use diltiazem in the ER. And if you start with metoprolol, they can't really switch over immediately. So that's kind of that. Not going to get any further into the why we don't have DILT on the truck debate. Very, very messy debate. Last treatment path we're going to go over is the synchronized cardioversion. So we'll go over our dose first. If we have a regular narrow complex, we start at 50 joules, regular wide complex 100, and an irregular narrow complex 120. Indication, unstable tachycardia. Contraindication, stable tachycardia or cardiac arrest. So we know we're synced up on our monitor when we have these arrows over our R waves. How it works is we deliver a shock immediately after the R wave, which kind of temporarily stuns the cardiac cells and it terminates the arrhythmia. Special notes, you have to hold the shock button as the shock is delivered at a very precise moment. So if you press it and it's not ready to deliver that shock because it's not sensing the right moment, it's not going to deliver. So you can press it as many times as you want. You might get lucky on one, but you usually have to hold it. Another special note, kind of like with the adenosine, you want to hit print on the monitor prior to doing this, just to make sure you get the rhythm before and after, and you can capture the conversion. But yep, you have your markers over the R wave. That means you're synced. Um, the reason why we don't just kind of let it rip is we don't want to deliver this shock in the second half of the T wave. The second half of the T wave is the relative refractory period, where the heart is beginning to repolarize and get ready to send another signal. But the thing that's significant about the relative refractory period, if there's a stimulus that's strong enough, to cause a depolarization. So it has to exceed the normal threshold to initiate a depolarization. Um, if that occurs in the second half of this T wave, it can cause VFib. So if you ever heard R on T phenomenon, that's what we're referring to. So basically, some stimulus is delivered in this time frame um, while the heart is trying to restore its electrical activity to get ready to beat again. Um, but you deliver it here, you deliver a large amount of energy. It depolarizes the heart at the wrong time. Patient goes into VFib. Why we don't cardiovert when they're in cardiac arrest or synchronized cardiovert while they're in cardiac arrest is because there's no reason to. You know, you're not going to make them any more dead. So that's why we just kind of shock. So we'll just quickly run through the protocol. We hit basically all of this. If you're an EMT, airway management, you're gonna go through your algorithm. Again, BLS before ALS, address those ABCs. If they need oxygen, get them oxygen. If they need help breathing, uh, you can bag them. Request ALS and make sure if you're trained, so which everybody is here, um, perform a 12 lead so you can hand it off to the medic. For advances, IV IO access so we can readily push meds. It doesn't say it, but fluid is probably a good start for a lot of these patients that are experiencing tachyarrhythmias. Perform your 12 lead ECG and get a medic on the way. Not going to hit this too much because we went over the whole stable versus unstable and our dosages. Basically, all these ramp up to 200 when it's all said and done for synchronized cardioversion. Um, but we should consider pre-medicating our patients. 3 milligrams of midazolam, IV INIO, um, or fentanyl, 1 mic per kg with a max dose of 100, IV INIO. Um, if you do not want to pre-medicate because they are very, very unstable, then make sure we medicate after uh, because shocking someone in the chest is not going to feel good. We can be a little nicer to our patients. If you are unable to synchronize, so that R wave um, just will not sense and you can't get the sync marker, um, or the patient is incredibly unstable or unstable, or it's polymorphic VTAC, which you're not going to be able to sync. You defibrillate once at 200 joules. I'll make sure we didn't miss anything. Nope. So this is the one treatment for SVT that we, or narrow complex tachycardia, we didn't go over. Um, you hear a lot of people say a vagal maneuver never works. We actually have seen on our shift this work 2 or 3 times over the last 6 to 8 months. Anecdotal, but usually patients on the younger side are more likely to have this work. So what we're gonna do, you have your patient. Well, you can start by just asking them to basically try to bow down. You can see what they're having a bowel movement. Bear down is the phrase I was looking for there. So bear down, not bow down. Make it seem like they're trying to have a bowel movement. Um, then we're gonna give them a 10 ml syringe, have them seated in an upright position, have them blow into the syringe, and then as they're blowing the syringe, drop the head of the stretcher and raise the legs up and hold for a minute, and then return them to a seated position. Also, very good idea to hit print on the monitor before this in case you get a successful conversion. Um, we had one where we did remember to hit print, and the conversion was pretty cool to see. We'll just hit real quick. Polymorphic VTAC with the pulse if they're somehow still producing a pulse with it. That's going to be 1 to 2 grams of mag sulfate diluted in 50 to 100 mLs of D5W. Give it over 15 minutes. Again, not a very likely scenario. Quiz. So just want to hit this one more time before we end the recording. Um, there is a ALS quiz link for advances and paramedics right here and a BLS quiz link for EMTs right here. Do not take both because that makes my life difficult. And if you take the wrong one, you're not going to get credit for the training. So just be very careful when you click, make sure you click the right one. Thank you very much for watching. Hope you're able to learn something. Have a good day.